Okay, so we had left CVA, so Mackenzie, Jess, and Caitlin were presenting on kind of what this looks like.
So a CVA is a cerebrovascular accident, which is caused by a lack of blood flow to the brain, which can be ischemic, which is a vessel blockage, or hemorrhagic, which is a vessel rupture. Left strokes are the most common, and so are ischemic strokes, which happen at 85%. There's some non-modifiable risk factors, which include ethnicity, age, sex, and genetics. And then there's also some modifiable risk factors, which just means you can change, which include hypertension, smoking, obesity, poor diet, low physical activity, diabetes, alcohol or drug use, poor cardiac health, and cholesterol levels. Some physical changes that you see with a left CVA include voluntary movement and coordination issues on the right side, sensation issues on the right side, dysarthria, which is muscle control of the mouth and lips, apraxia, dysphagia, visual deficits in the right visual field, which are homonymous hemaniopia. We also see cognitive changes, which include memory issues, aphasia, problem solving, and neglect. And then some emotional changes that can happen include irritability, impulsiveness, carelessness, fear, anger, frustration, sadness, anxiety, and depression. Yeah.
Okay, so some assessments that we found, I kind of broke it into 3 different parts: the motor and sensory. You could do the Fugel-Meyer assessment of motor recovery after stroke. For cognition, you can do the mini mental state examination. And for vision, I just said visual screenings. And if you're actually going in to see a patient, I think you can have more in-depth assessments in mind. And then if you see a deficit in more of these like screening shorter ones, you can kind of dig in to see where that would be. But just for a timing sake, these ones are all pretty short. So these are the ones that I chose that I feel like could be helpful. So the first is the Fugel-Meyer. This is on it's based on a 3-point ordinal scale. You grade them on can't perform, performs partially, or performs fully. There are 5 different domains, so it measures motor function, sensory function, balance, joint range, and joint pain. It is a free assessment. It takes about 30 minutes, and they have different versions for ages. It goes 13 all the way up to 65 and older. You just need some equipment, so even though it's free, you do need a couple things in order to test it. But this is just a good, obviously we also want to do functional assessments, but for the more standardized side of that, if you kind of know where some of the motor sensory kind of challenges are, you can anticipate where the functional deficits may be and kind of adjust for that. So this is what it looks like. I just threw in screenshots online. It just goes through on different joints and different areas of the body and what they have in those areas. So for the mini mental state examination, this is created for older adults. It takes about 5 to 10 minutes, so it is more of a screening than a diagnostic, just kind of seeing very, very generally if they have any deficits, and it screens for orientation, registration, attention, calculation, and recall. And so I threw in a screenshot of this too, but it's, we've looked at it in a couple classes too, but I feel like this is just a good, very general one to look at. And then if they're scoring low on that, you can kind of look at what that looks like and find a more specific, more in-depth assessment for that type of cognition. And then vision screenings, I think this is important just because of what we've learned about the brain and where strokes can happen and the visual deficits that can come with that. And so I just put in there some of the visual field testing and tracking assessments, screenings that we've done for vision, just to make sure that they're intact, and if not, being able to refer them out for that. But like I said, with all of these assessments, it's ideal to do functional assessments as well, but these kind of help give a baseline and some numbers for insurance and things like that in order to see kind of where these people are at.
Okay, and then 3 interventions that we decided on are art storyboard, mock store, and then ADL charades. So first is the art storyboard. We would work with the clients on creating a storyboard or collage. You can use cutouts, drawings, or paint to create a personal story, such as a favorite memory. Then once the patient has finished, have them share/narrate what they've created. This intervention helps to engage the patient's affected side while also working on fine motor and a meaningful task. By having the patient narrate what they created, you're also working on communication skills. The mock store, you can set up the clinic or wherever your environment you're in as a mock store and give the patient a short shopping list and have them go shopping. This intervention allows them to navigate the space to work on mobility, coordination, using visual scanning and utilizing their affected arm to grab the objects that are on the list. And you can also add a communication aspect towards the end of the mock store by having them check out with a cashier when they are done shopping. And then lastly is ADL charades. Have the patient draw different charade cards that include everyday tasks such as showering, cooking, brushing teeth, and having them act out or describe it with a therapist. You can take turns going back and forth and have the patient guess what they're doing. The rationale for this is the intervention supports with motor planning, communication, and practice with everyday ADLs. Here are our references. Thank you.